Welcome everyone to our very first Health Research from Home webinar. We have guests here from universities across the UK and across the globe. We have people from organizations such as the NHS, NIHR, and even the FDA. We have people from companies across the digital health and health technology sector, as well as pharmaceuticals. We are very excited to have you here. Thank you for joining us. And now I am going to introduce your hosts. My name is Rachel. I am the Strategic Partnership Lead for Health Research from Home and also an ex-Google Health Fitbit PM. Together with my colleague, Coral Stevenson, we are going to be your host today. Let's start with some housekeeping items. This webinar is going to be recorded. We are going to pause the recording during the Q&A session, and you will be able to access the recording through our website. You will be all muted throughout the presentations, but if you want to ask a live question during the Q&A session, the host will unmute you. You are encouraged to use the chat box to talk with each other or to submit technical questions to our host. Now, you are also very much encouraged throughout the first speech to use the Q&A box and use the upvoting button, the thumbs up, to indicate any exciting questions for you. We will have two speakers today. After the first speaker, we will have a Q&A session, then a second speaker, and then I will be back with announcements. And without further ado, please welcome Professor Will Dixon. Will is a professor of digital epidemiology and also a hospital doctor. Will's speech title is Health Research from Home Introduction. And now please remember, again, you can submit questions to Will throughout his presentation in the Q&A box at the bottom of your speech. Will, now I pass it to you.
Thanks, Rachel. So if you unshare. And just check that you can see that all right, Rachel?
I can see it well, yes, and I can hear you.
Okay, well, welcome everyone to this first webinar of Health Research from Home. It's a real pleasure to have you with us today. My name's Will Dixon. As Rachel introduced me, I'm both a hospital doctor and an epidemiologist. So I work at Salford Royal Hospital in Greater Manchester and at the University of Manchester. And these roles are complementary. In my clinical work, I collect information from patients so that I can make informed decisions together with them about the best management. And as an epidemiologist, I try and analyze data across populations in order to generate answers to questions that really matter to patients and the public, such as how quickly will this drug work that you're about to prescribe? Both of these roles require me to collect information directly from patients, including between routine visits, either to the clinical services or to research visits. And going back 10 years, I started wondering, well, could we collect this information directly from patients and the public using their own consumer technology? And wondered whether we could use that to support self-management, to support clinical care, and to support research, and whether we could align these three things. What I'm going to talk about today is a case study from the use of patient-generated data for research. And then that is going to lead on to how we came about setting up Health Research from Home and introduce this new research program to you and the three different work streams within it. We're just getting started with Health Research from Home, and we really want the program to meet your needs as this emergent community. And so I would really encourage you to reflect on whether we're delivering what you need, what you might want in the future, and provide us with ideas via the chat in the webinar today, via the survey that you'll have after the webinar, or directly via email in the address at the bottom right. I'm going to anchor the talk in the life course of a study, and this is written down at the bottom of the slides, going from the idea of answering a research question through developing a protocol and a grant application, through finding the technology partner, to collecting the data, to doing the analysis and generating the results. But what we're going to try and do is not just think about the scientific principles here, but also go behind the scenes and think about the practicalities of running such a study, learning both what we've done well and what are some of the challenges. So starting on the left of this timeline, let's begin with a research question and a protocol or a grant idea. So this is an application that we submitted to the MRC's Confidence in Concept bid back in 2014. And the project title was Development of a Validated Clinical and Research Tool for Measuring Musculoskeletal Disease Severity Using Passive Motion and Position Sensing. The argument and the story went like this. As I've described, I work as a rheumatologist, and my opening question in clinic is, how have you been in the last 6 months? That is the foundation of me making decisions about people's treatment, and yet is one of the most difficult questions you could possibly be asked. Using technology, we have the potential to track symptoms that could provide a much clearer picture of how somebody had been. And if we have a clearer picture, that could lead to better patient outcomes. And indeed, that's turned into a whole research program in its own right, something called ReMOR, or Remote Monitoring of Rheumatoid Arthritis. However, even at the start, we recognized that the burden of tracking daily symptoms over years would be prohibitive. At some point, people would disengage. The opportunity, though, is that in arthritis, as your disease severity changes, so does your pattern of physical activity. So if you're having a flare of your rheumatoid arthritis, you may take to your bed, which is going to be very different from when you're in clinical remission. And therefore, there is this opportunity to passively monitor disease severity using consumer devices, the things that you're carrying around in your pocket, in your bag, or wearing on your wrist. If we are to use passively monitored disease severity, that requires us to develop a validated measure of disease severity. And we can only do that if we correlate the activity patterns with regular measures of disease severity. So you need frequently reported symptoms. And as we said in the application, unfortunately, it is unlikely that patients will provide self-reported disease severity over months for the sole purpose of algorithm development. Please, would you like to take part in a study that's developing a validated, passively collected disease severity measure for rheumatoid arthritis? People would have lost what we were saying when we were halfway through the sentence. So we recognize the need to design and run an exemplar, collaborative and participatory clinical research study that patients understood, where there was a high probability of long-term regular engagement on a daily basis. And for that reason, we said we will therefore run, as a vehicle for data collection, a study to examine the association between weather and symptoms of arthritis. This is something that comes up in almost every clinic that I run. People tell me that their symptoms are better or worse because of the pain. And yet we've never really had an answer to that question, despite the belief being around for millennia. So in a figure, this is what we would ideally like to have done, measuring disease severity tracked every day via an app, and then using the accelerometer within the device so that we can develop this validated measure of disease severity. And we decided to hide that behind a more understandable study called Cloudy with a Chance of Pain, looking at the association between weather and pain. So back to the protocol and grant, we needed to assemble a team, and the team, you will learn in a health research from home, is really important. We have to have people across disciplines. This is a necessarily interdisciplinary world. And so I have expertise from clinical care and rheumatology, as well as epidemiology. And then we expanded the team out to include people with expertise in health informatics, in medical sociology, so we understood why people would engage with this and how we might improve the user interface design so that people stayed engaged for months. And of course, if we're looking at the weather, we needed to have somebody who understood the weather. So we've got a good idea. We think that the data items could be collected with smartphones, but how are we going to find the technology partner? Well, with this in mind, I attended a conference called Medicine 2.0 back in 2013 and happened to come across Bruce Hellman in the poster session. Bruce is the co-founder of uMotif, and here he was presenting a poster about the other two aspects of how patient-generated data can support patients and the public through self-management and clinical care. So their platform, uMotif, was doing that, but I saw the potential of reusing their platform for a research study. They have a motif, it's a 10-item motif, and it looks a little bit like the flower that you can see on the right. The 10 items, each one of the petals was a measure of severity, and it had a 5-point ordinal scale. So you could score 5 different ways for each of the 10 items. At that moment in time, it wasn't possible to change the number of variables, so we were stuck with 10, and we couldn't change the number of categories within one variable, although you can now. What we could do was change the wording of the questions for any of those 10 questions. So would that work for us? Well, we had to think a priori of what is it that we need to collect for this research study. Cloudy with a chance of pain, we obviously needed to measure pain, so that was our primary outcome. Our primary exposure was the weather, but we wanted people not to self-report it. We wanted to use the sensor for that. So we pulled data from the local weather station via the smartphone's GPS. We needed to understand the nature of the relationship between weather and pain. Was it a direct causal relationship, or did it go via other mechanisms? So, for example, if it was a sunny day, did you spend more time outside doing physical activity, which then increased your pain? Did a sunny day improve your mood, which then in turn improved your pain? And if we're to understand that, we needed to measure it. There were other things that we thought might confound a relationship, but they were considered somewhat difficult and perhaps only partially important for the research question, and we intentionally excluded those. There were other things that we thought would be interesting for patients to track, and looking at the relationship between weather and pain and some of these other variables like sleep and fatigue. And all of those things that we wanted to measure were indeed possible to measure on a 5-point ordinal scale. So it looked like the uMotif platform would work in partnership with Cloudy. Also, we were really impressed by the look and feel of the interface. It looked simple and intuitive. It looked engaging. Patients got graphs of their symptoms back. So we thought this was a way of keeping people engaged over months. However, at the time, the uMotif platform didn't have a way of collecting GPS data and didn't have a way of collecting raw sensor data to allow us to develop this validated algorithm. And so in our funding bid, in discussion with uMotif, we included costs to develop that. And the technology partner were interested in that because that also became a potential feature of their future platform. We recognize that this process is somewhat challenging, and in Health Research from Home, over the course of the next few years, we want to help facilitate the discovery of good partnerships between academia and industry, and we can tell you more about that in future meetings. So moving from left to right along the bottom, we've thought about what we might like to collect in terms of data items, but now we layer on what is a fundamental foundation of good health research from home. You have to work with patients and the public from as early as possible, because it's them that we're asking to contribute their data day to day. And it was at this stage in our pilot study that we got the patients and the public involved. So we had a technology partner, but we wanted to test it and develop it with our patient partners. So we expanded the team from the research that you've seen out to an additional patient and public involvement and engagement group. And you'll see more of both Carolyn on the right and Karen on the left through the course of the presentation. We settled together on these 10 different data items within the motif, plus collecting data via the GPS, linked to weather data, plus collecting raw activity data via the accelerometer. And just to show you the impact that the patient and public involvement has, it led to the reversal of the scales. uMotif had previously thought that the flower should look full when everything was good, which meant that the 5, the full petal, was good. But patients said, well, I'm used to scoring pain where 1 is good and 10 is bad or 5 is bad. And so we inverted the scale. We also modified the wording where patients felt that talking about depression was more negative than could be explained by measuring mood. So we decided what to collect, but could we actually collect it? And this was the purpose of this pilot study. And we were delighted to see that the GPS that we were collecting could indeed be linked to the weather stations locally, generating the temperature for the first 5 days for this first patient, and that the track symptom data then correlated. Although, interestingly, this correlation was in the opposite direction from what we were expecting. We tested how commonly people would collect the data, and we see here that the engagement was really good. Now, if you just collect this quantitative information, you don't know why the engagement is good or bad. And so we did interviews and focus groups with the participants, and they told us the following things. I know myself the weather is a massive factor. Everybody I know has got a smartphone, so if they can improve people's health and their condition and how they're managed, then brilliant. So patient understood the research question and were motivated to contribute to that. I'm really impressed with it. I think anybody can use it, even people that are not technically minded. So the app was simple and easy to use. I'm a bit of a nerd, so I will probably have a look at those graphs to see how I've been scoring during the pilot. And this is returning something to patients in the public for their participation. Here, just seeing a score of their symptoms was felt to be really useful. So those are all the good things, but the qualitative research also throwed up something that was fairly fundamental to our study. We developed this capture app to collect the GPS and the raw sensor data. And patients told us, I just left the phone on the side because the battery kept going all of the time. I think because the capture app was running all of the time, it kills the battery and you're constantly having to charge it. So if your phone's plugged in next to the kettle, it's not doing a very good job of measuring your physical activity. So the early discovery of this was very important for us. So we're partway through the timeline of this pilot study and we've got to the data collection stage. But at that point, we then had an unexpected opportunity. The team from Trust Me, I'm a Doctor got in touch with us because they were looking for projects where patients and the public use their own technology. And they wanted to come along and film us. Now, our pilot study had been going well at this point, as you've seen, except for the sensor data collection, although the weather and pain question was going exceptionally well. Trust Me, I'm a Doctor has viewing figures of 2 million people, and we wanted a lot of people to participate. So this seemed like an excellent opportunity for recruitment for us. So we decided to go back to square one and rethink the protocol and the grant. And Arthritis Research UK were kind enough to receive a grant application from us for solely the weather-pain relationship and what would become Cloudy with a Chance of Pain. So we submitted the application. We expanded the team. So Carolyn, one of the patient public involvement group, became a formal patient partner as a co-applicant. We expanded the analysis team and project management, and we also built in partnership with data visualization experts so that we could run a citizen science study. We then come to the recruitment time when Trust Me, I'm a Doctor shows. It airs. Chris Van Tulliken did a fantastic job of directing viewers to our website, but then we got the opportunity to be on BBC Breakfast with viewing figures of 7 million. But I'd just like to highlight here that the partnership with our patients was really wonderful here. And it was Carolyn who really stole the show and made it relevant to everyone watching the programme. I'm just going to show you a short clip from BBC Breakfast.
It is 9 minutes past 7. We'll have the weather forecast from Carol in just a few minutes. But what if those downpours don't only mean you need to remember your umbrella today?
Because some people claim the weather can affect their health. And our researchers want to find out if they're right. They're using a smartphone app to get people to record how they're feeling and then linking it to local weather data.
It's very interesting, isn't it? Breakfast Jane Cubbin has been to find out more for us.
It is so bad when it's at its worst. It is almost has no words to describe it. It's debilitating. It's really at the core of your bones.
Carolyn was diagnosed with arthritis aged just 18.
It's horrible.
Horrible. And you think weather related?
I think that the weather is related to an extent.
But to what extent and why?
That is not.
So after the BBC Breakfast broadcast, they directed people to our study website, Cloudy with a Chance of Pain. We'll share a GitHub link with you. You can follow that and it'll take you to the site. And we were really impressed with the recruitment. We'd hoped to recruit 2,000 people across the year. We'd never done this before. We had no idea of what was possible. And after Trust Me, I'm a Doctor launched, we'd recruited that 2,000 people within 4 days. Once we aired with BBC Breakfast, we had this odd graph shape of vertical recruitment where we were recruiting 1 person per second. And ultimately, we recruited over 13,000 people across the country from every single postcode area in the UK and collected 5.1 million symptom scores. Now, we started patting ourselves on the back at that point, but then this happened. What a waste of taxpayers' money. We had a feature on ITV News, who also broadcast about the study at the launch of the project. They didn't direct people to our study website. They directed viewers to their own study website, their own website, asking whether you think the weather affects pain. And down at the bottom, there are several hundred comments, starting with this. I have fibromyalgia, so of course weather affects my pain. They could just have asked doctors to confirm that. Oh, for goodness sake, everyone knows the cold, damp weather adversely affects aches and pains. What a waste of time and money. They need to get a proper job. And there were a whole series of comments ending with this one. Anyone with a modicum of sense knows the weather affects illness and pain. Scientists do what they do well, wasting money on worthless tests that benefit nobody. So seemingly problematic, but actually quite interesting and challenging for us in that this relationship that everybody knows about, in fact, everyone who was commenting on it was telling us a different aspect of the weather influenced their pain. And so there was a need to answer this question. And we knew that we needed to respond to this so what question. And let me come back to that later. So we started the recruitment. We wanted to track daily symptoms for 6 months or more, a really big ask. And so we built into the study design as many things as we could think of to retain our participants. Daily prompts via a notification via the smartphone. We sent out a weekly newsletter. We allowed people to see their symptom graphs. We set up an online patient community where they could discuss the study or living with chronic pain. We ran a citizen science experiment and did lots of public engagement, taking the citizen science experiment out on the road. Moving along the timeline on the bottom right, we have to think about data storage and linkage. And this is one area that I think at the time we just didn't do as well as we might have done. I just searched back through my email history and found this quote. So a discussion between the established researchers and some of the newer researchers in the team. And researcher 1 says, in the DAT file provided, what does value stand for? And researcher 2 by email says, value stands for pain severity with the range, this range. Now, we shouldn't have to have exchanges about the data via email, and we have done better since then. We had to move at fast pace as a bit of an excuse, but certainly this has led to us understanding the importance of a really good data dictionary and labeling of data items as well as possible. Onto the analysis, I went back to our application to Arthritis Research UK to see what we said we would do about the analysis. And actually, we did a pretty good job of describing what we ultimately delivered. So we said the proposed analysis would be a self-controlled case series. I remember at the time thinking, how are we going to analyze this time series data? Because we didn't have experience of doing that in more traditional epidemiology. So having written that and now having run the study and having got the data, we then looked around to find people with real expertise in this area. And we reached out to Malcolm McClure, a Canadian epidemiologist who invented the case crossover design, comparing moments at which you have an event to moments at which you don't have an event and looking at the exposures around those time periods. So Malcolm kindly joined the study team, as did Antonio Gasparini, who's doing the most recent iteration of Malcolm's original method many decades earlier, as well as some others. And so years after we started, we then generated the results. We found that pain was associated with low pressure, high humidity, and high wind speed. And visually, you can see it quite well here, in that the days with the lowest percent of pain scores on the left had a really high pressure area bang over the middle of the UK. And on days with the highest 10% of pain scores, there was an area of low pressure. So pain is associated with low pressure, you can see very clearly. Normally, we publish this in academic journals, which indeed we did, and you can find that paper via GitHub. But we also knew it was really important to reach out to patients and the public. So we wrote a draft press release. We worked on that with patients, with our funders and others, and put it out. And the next morning, we were delighted to see that we were the 5th item in the BBC News app. It was featured on the Today programme, and we had lots of press attention. More importantly, though, we were able to go back to our original cohort via the route that we had recruited them. And here, Carolyn and I are on BBC Breakfast talking about the study results. And you can see the study results video via GitHub too. And just to add that I think that this need to feedback study results to patients and the public in real time has been completely transformed by what Tim Spector and colleagues have done through the COVID Zoe symptom study app, where everyone was tuning into his webinars to learn about the latest science that had been crowdsourced from the 4 million people who were participating. And indeed, the COVID Zoe symptom study is one of our 2 driver projects for Health Research from Home. So we've got the results. We were aware of some of the challenges, and we thought, who better to answer this question than our participants? So here's a short video that we made with people who'd taken part in the study.
Cold, windy,
hot, dry, damp, overcast,
pressure,
grey,
a change in the weather,
very warm,
raining. It came like an express train.
household chores and gardening are out of the question.
Is a horrible situation.
Everything hurts and I feel like I'm running out of energy.
I won't be able to walk. The research really matters to me.
It's necessary for everyone to be aware.
Hopefully manage my pain a little bit better.
To record 6 months of symptoms.
This could be extremely useful.
It might prove that I'm not imagining that my symptoms are worse.
Motion is lotion.
I think that taking part in research studies helps you gain a little more control over your condition.
And if we could put sunshine in a bottle.
Rosalie,
Roger.
Janet,
Nora, Belinda,
Karen versus arthritis.
So that takes us to the end of Cloudy with a Chance of Pain. But I think on reflection, it really showed us the tremendous potential of doing novel population health research using smartphones. But it also told us that there were many practical challenges along the way. That led to us running a series of digital epidemiology summer schools in Manchester over the last few years. We had a roundtable on the future of patient-generated data for UK health research. You can find that publication on GitHub. But ultimately, it led to MRC funding for Health Research from Home so that we could share not just our lessons learned with the wider community, but from those across everyone who was trying to do similar types of research. I need to thank the many, many people who contributed to Cloudy before moving on. And so move on, I shall though, to Health Research from Home. And I'd like to introduce you to the programme. Hopefully illustrated through that case study you can see the enormous opportunity of using smartphones and wearables for health research. It provides this global opportunity for patients and the public to participate in relevant and meaningful health research. And that opportunity is because you can collect new types of data. You can collect symptoms that are tracked through time. You can measure sensor data. That could be physical activity. It could be heart rate. It could be GPS linked to air quality. It could be a whole range of things integrated into people's daily lives. You can collect the day-to-day changes of symptoms through time, the day-to-day changes of disease, the day-to-day changing exposures, and that can be measured in between when we usually get health information. And as we've seen in our study, as we saw in the COVID Zoe symptom study, you can have mass participation. They recruited 1 million people in the first day. Patient-generated health data is valuable in its own right. It's even greater value if you can link it to other data sources such as NHS data or biological data. Here's an example of a patient trying to work out their own relationship between diet and symptoms. We want to help patients do this in a more scientific way, not just for themselves, but across the whole population. Despite there being case studies of good success, though, patient-generated health data research has not delivered at scale because there are so many different obstacles to overcome. There's undervalued importance of good public and patient involvement and engagement. It can be difficult to access data collection tools and platforms. The science is perhaps not yet as mature as it will be in the future, and teams typically have gaps. This is necessarily interdisciplinary. Collectively, there is a lack of know-how. So in health research from home, our primary aim is to share best practice for using smartphones and wearables for population health research. Our purpose is to improve the lives of people living with long-term conditions. The vision is to make the UK a world leader in large-scale, high-quality health research using smartphones and wearables with linkage to national health data assets. We'll do this by building a collaborative community sharing know-how, skills, and experience to catalyse and enable future health research from home studies, with the values of creating a cross-sector environment and public partnership where excellent ideas will thrive, inclusive of all perspectives and disciplines. There are 3 work streams in the programme. There's an events programme, of which this webinar is part of. We'll develop a repository of shareable resources, and there'll be 2 driver projects, which you'll hear one about today. One is about physical activity patterns after knee replacement, the second about the long-term outcomes of COVID. The events programme is monthly webinars. This is webinar 1, monthly advice clinics that you can book into starting in September on information governance, on PPIE and technology. An annual event that is tentatively scheduled for February, the first one, an annual analysis challenge likely next spring, and grant writing retreats. For the webinars, we'll have an invited speaker talking for the first 25 minutes or so with very clear learning objectives. We'll also ask them to tag what their talk is going to be about, be it the clinical area, the types of data, the type of technology, so that you understand what the webinar will be about. We'll also have a talk from an earlier career researcher aligned to the topic of the first invited speaker, with a question and answer session following that. And then the last 15 minutes will be some news and updates about the driver project, so you can follow these 2 projects through their live course over the next 2.5 years. There are resources, pre-webinar, the learning objectives, additional resources via GitHub, and post-webinar, you'll be able to see the videos if you attended or not, and have a discussion with others via the GitHub page. We've got the programme laid out for the next 6 months, and we'll post this on our website so you can see it. But as you can see, a range of different disease areas or aspects of health research and home studies. We want you to help shape the programme, as I've already said, so please do get in touch. You can influence what happens beyond the 6-month webinar. So we've got 3 work streams. We're also thinking of additional things, perhaps working groups to define best practice in a particular area of health research from home, perhaps developing novel data collection tools, or maybe your idea will go onto the list, please do let us know. So just to finish, Health Research from Home, we want to share best practice for using smartphones and wearables for population health research. We want to do that across disciplines, across sectors. We want to bring the community together to be more dragon. So thank you very much indeed for listening, and I hope you enjoy the rest of today's webinar and indeed the rest of the whole Health Research from Home programme. Thanks very much.
Thank you very much, Will, for an exciting presentation, and time for our second speaker. Our second speaker is Shuai Shao. Shuai is a research assistant at the University of Manchester, and Shuai's speech title is Paprika Project Introduction. Please welcome Shuai Shao. Shuai, I pass it to you now.
Thank you, Rachel. I will share my screen. All right. Can you see my screen?
Yes.
All right. Hello, everyone. My name is Shuai Shao, and I'm a research associate. I hold a PhD in wearable-based human activity recognition. It's my honor to have this opportunity to present our driver project, Paprika. Paprika stands for Physical Activity Patterns After Knee Arthroplasty. This retrospective cohort study links activity data to NHS data, aiming to provide deeper insights into the recovery process post-knee replacement surgery. Additionally, we aim to learn how to successfully conduct such a linkage study. Knee osteoarthritis affects 1 in 5 people over the age of 50. Symptoms include pain and limitations in function. Current treatments include physical therapy and pain-relieving medication. Unfortunately, there are no disease-modifying treatments and patients may progress to surgery. The potential benefits of surgery include lower pain and better mobility. Before considering surgery, patients need to understand the benefits and harms of the operation. We know how well pain improves, but what activity will people regain following surgery, and how quickly? This is much less clear. We can do research in populations of people having joint replacement to fill this gap. Traditionally, questionnaires are used to gather patient recovery data, which can be time-consuming and costly. Well, we could initiate a prospective cohort study to collect new data over the next year. We aim to adopt a more efficient approach. By using existing data, we can start our research immediately and achieve our goals in a more cost-effective manner, making use of the results already available. To make our research more effective, we have chosen to conduct a retrospective cohort study. This approach allows us to use the existing data we already tracked in NGR. We can also collect the existing activity data among the patients from their wearable devices. The problem left is how to link the existing NGR data with the patient's activity data. As we may know, the activity data can be collected from patients through wearables and smartphone applications. There is a significant gap when it comes to integrating this data with NHS data. The NHS data do not include detailed activity data, making it challenging to cross-check and validate the recovery process based on physical activity metrics. This lack of comprehensive data integration limits the ability to fully understand and optimize the recovery journey for knee replacement patients. Our research is to explore a possible solution to link activity data and NHS data. Our study has both clinical and methodological aims. Clinically, we want to generate insights into physical activity patterns after knee replacement surgery, enable patients and clinicians to make more informed decisions before and after surgery. Methodologically, we aim to learn by doing in terms of how to conduct research studies that link person-generated health data with NHS data. To participate in our study, adults who had knee replacement are eligible. Participants must have monitored their physical activity through a smartphone application or wearable device, both before and after their knee replacement. They may need to be able to read and understand English, to have support, and be willing to provide informed electronic consent. Our study design involves several steps: advertising the study to patients and the public, directing them to the study webpage, viewing study information, checking eligibility, and confirming their email address. Participants will provide personal identifiable information, complete a user consent process for assessing physical activity data, fill out a short questionnaire, and optionally enter a prize draw and provide feedback about their study experience. We will then pull the consented data about historical physical activity, share it with NGR for linkage, and provide the final dataset for analysis. Our study design follows a detailed and secure workflow to ensure comprehensive data collection and analysis while maintaining participant privacy. We start by utilizing existing NHS data from the NGR environment. Participants will provide their e-consent to join the study. We will collect identifiable information, including their name, gender, and NHS number. Additionally, we will gather research data, which consists of physical activity data from their wearable devices, survey response, and feedback. To protect participant privacy, identifiable data will be sent to NGR directly with a secure method to match the data in NGR. On the other hand, the research data is stored in a secure database designed for research purpose under university environment. Each participant's data is assigned a unique study ID to facilitate secure and anonymous tracking. For each participant, the NHS number collected by the study will be matched with the NGR data. After successful matching, the NHS number will be replaced with the study ID to anonymize the data, to ensure that personal identifiers are moved and only the study ID links the data. Next step, the research data with the same study ID will be sent to the NGR environment. We will link the research data and NHS data with the study ID. This comprehensive linkage dataset will be used for in-depth data analysis in a secure NGR environment. In summary, it is possible to link existing person-generated health data to NHS data, which enables us to address important research questions that matter to patients. This approach brings efficiency in study design and unlocks major research potential. However, there are many challenges to understand and navigate. Our collective experience, including both success and failures, will help the community to conduct better science for public benefit. We'll be sharing progress on the project in real time during the webinar series. Currently, we are working on an NGR application to request permission to access NGR data. We hope to see you at the next seminar where you can hear more from us. Thank you.
Thank you very much, Shuai, for the very comprehensive introduction of the Paprika project. And next, another unique and super exciting opportunity for you for your specific project. So we know that conducting health research using patient-generated data can be quite complex, especially for the first time. So we want to help this community to create more of these researches in the future. Therefore, you will have the opportunity to book a one-on-one session with an expert in their field starting from September. And you can book this through the confirmation email you received for this webinar. So first, our technology clinics might help you to answer questions such as what devices I should use, what data collection platforms I can use, issues related to backend, front-end architecture, infrastructure, and apps using existing technologies. And then second, the IG clinics could help you to identify, understand issues, information governance issues related to your specific project, and also help to resolve those issues. And then third, public and patient engagement. The PPIE clinics might help you to answer questions such as, who should I involve in my research project? How should I set up a PPIE group? Or how to serve traditionally underserved communities? Now, as you can see, just from these clinic sessions, this is truly an interdisciplinary field, and it even takes cross-sector effort to advance this field. So now, if you are someone who is excited about advancing health research using smartphones and wearables, then Health Research from Home is an excellent community for you to advance this field. And I really hope that this webinar give you a taster of what is possible, and you are excited to join this community and really use and leverage the resources what we are creating for you throughout these webinars. Now, with that, I want to say thank you for your attention today. And I am excited to see you at one of our future events. Have a great afternoon, everyone. Feel free to grab these resources. I leave it on the screen in the next couple of minutes.
And Rachel, people can sign up to the newsletter via the website, right? So we'll send out news via that route, and please share that on with everyone if you enjoyed. Yeah, and I'd really like to second Rachel's thanks to everyone for attending. It's been wonderful, and to thank the team for getting us to this point with this new community. Thanks very much, everyone.